في ساحة للعلم كنا نلتقي، والحب والإخلاص زاد قلوبنا، نمضي إلى نور اليقين ونرتقي قمم الفلاح وتاجنا أخلاقنا. في ساحة للعلم كنا نلتقي، والحب والإخلاص زاد قلوبنا، نمضي إلى نور اليقين ونرتقي قمم الفلاح وتاجنا أخلاقنا. نسعى إلى طلب العلوم وفهمها حتى تضيء بشمسها أرواحنا، للدين والدنيا جمعنا أمرنا كي لا يضل عن الحضارة ركبنا. نسعى إلى طلب العلوم وفهمها حتى تضيء بشمسها أرواحنا، للدين والدنيا جمعنا أمرنا كي لا يضل عن الحضارة ركبنا.
Growth. Growth is an increase in the size or number, or changes in the amount of living substance occurring in a process of development. Factors affecting the growth. 1. Genetic factors hereditary play a significant role in regulating growth patterns. 2. Environmental factors can modify the outcomes of normal growth patterns depending on the time and type of environmental influence. 3. Combination of genetic and environmental factors. Human growth consists of two phases: prenatal, before birth; postnatal, after birth. The normal human development consists of three phases. Phase 1, formation of 3 germ layers, from fertilization to end of second week. Phase 2, the embryonic stage, from 3rd week to 8th week. Phase 3, the fetal stage, from 8th week to birth. By the end of 2nd week intrauterine life, the fertilized ovum implants itself into the uterine wall and it develops placental membrane. 3 germ layers are developed: ectoderm, mesoderm and endoderm, forming the trilaminar disc. Then trilaminar disc undergoes embryonic folding.
At the beginning of 3rd week of development, the ectodermal germ layer has a shape of a disc that is broader in the cephalic than in the caudal region. Then the ectoderm thickens and forms the neural plate. Sums of the plate make up the neuroectoderm and their induction represents the initial events in the process of neurulation. Neurulation is the process whereby the neural plate forms the neural tube. By the end of 3rd week, the lateral edges of a neural plate become elevated to form neural folds and the depressed midregion forms the neural groove. Gradually, the neural folds approach each other in the midline, where they fuse. As the neural folds elevate and fuse, cells at the lateral border or crest of the neuroectoderm begin to dissociate from their neighbors and form the neural crest. As a result, the neural tube is formed in the crest cells, which migrate will give rise to adrenal medulla, Schwann cells, melanocytes, meninges, adipocytes, neurons and glia.
Neural crest is ectomesenchymal tissue arising from the crest of the neural fold, and is considered to be a separate 4th germ layer that is capable of forming many different cell types and is highly migratory.
During the 4th week of development, a series of outbouchings of mesoderm appear on both sides of the developing pharynx. These outbouchings are called pharyngeal arches. 6 pairs of pharyngeal arches expand from the lateral wall of the pharynx. Soon after formation of the 5th pharyngeal arch becomes disappear after its formation. Pharyngeal pouches form on the endodermal side between the arches, and pharyngeal grooves or clefts form from the lateral ectodermal surface of the neck region to separate the arches.
By the end of fourth week, 5 primordial swellings consisting primarily of neural crest-derived mesenchyme appear around the stomateum and play an important role in the development of face. The single frontonasal prominence appears ventral to the forebrain. The paired maxillary prominences form the cranial part of the first pharyngeal arch. The paired mandibular prominences develop from the caudal part of the first pharyngeal arch. An ectodermal line depression called stomateum is separated from the primitive pharynx by the oropharyngeal membrane. The membrane later breaks down and stomateum opens into the pharynx. Bilateral oval-shaped ectodermal thickenings called nasal placodes appear on each side of the lower part of the frontonasal prominence. Nasal placodes are primordia of the nose and nasal cavities. Mesenchymal cells proliferate at the margin of the placodes and produce horseshoe-shaped swellings around these. The sides of these swellings are called medial and lateral nasal prominences. The placodes now lie in the floor of a depression called nasal pits. Each lateral nasal prominence is separated from the maxillary swelling by nasolacrimal groove. The maxillary prominences continue to increase in size and, laterally, merge with the mandibular prominences to form the cheek. Medially, compress the medial nasal prominences toward the midline and finally fuses with these to form the upper lip. The upper lip is formed by the 2 medial nasal prominences and the 2 maxillary prominences. The medial nasal swellings enlarge, grow medially and merge with each other in the midline to form the intermaxillary segment. The development of the palate begins at the 7th week of intrauterine life. The palate anatomically separates the nasal cavity from the oral cavity and structurally has a hard anterior component and a soft posterior component ending with the uvula. The palate forms from 2 major parts, the primary and secondary palates. Primary palate develops from the intermaxillary segment of the frontonasal process. Fusion of the 2 medial process with the frontonasal process results in the formation of the primary palate. Primary palate carries the incisive fossa. Secondary palate develops from the horizontal palatine processes of the maxilla. Its development characterized by the formation of 2 palatal shelves on the maxillary prominences, the elevation of these shelves to a horizontal position, and then the process of palatal fusion between the horizontal shelves. The shelves will also fuse anteriorly, upon the primary palate, with the incisive foramen being the landmark between the primary palate and secondary palate. This forms what is known as the roof of the mouth or the hard palate. The hard palate is continued deeper into the mouth by a fleshy extension called the soft palate. Bone growth.
The formation of bone is called ossification. During the fetal stage of development, this occurs by two processes: intramembranous ossification and endochondral ossification.
Intramembranous ossification involves the formation of bone from connective tissue. Mainly occurs during formation of the flat bones of the skull, but also the mandible, maxilla, and clavicles. The bone is formed from connective tissue such as mesenchyme tissue. The process includes the development of the ossification center, calcification, trabeculae formation, and the development of the periosteum. Endochondral ossification involves the formation of bone from cartilage. It occurs in long bones and most other bones in the body. It involves the development of bone from cartilage. This process includes the development of a cartilage model, its growth and development of the primary and secondary ossification centers, and the formation of articular cartilage and the epiphyseal plates. The structure in the cranial base which resemble the growth plates are synchondroses. A synchondrosis is a type of immovable joint in which the articulating structures are joined together by hyaline cartilage. Synchondroses are formed between the epiphyses, ends, and diaphyses, shafts, of long bones. It includes the numerous temporary cartilaginous junctions between diaphysis and epiphyses, in the immature postcranial skeleton and also in the regions of unossified cartilage, between skull components developing in the chondrocranium between the sphenoid and occipital bones. The most important synchondrosis in the growth of craniofacial region is spheno-occipital synchondrosis.
Human facial skeleton is unique. Craniofacial region is formed of 22 bones, 8 cranial and 14 facial bones inclusive of the mandible, the movable bone of face. Study of the postnatal growth of the craniofacial skeleton is intriguing because the remodeling pattern of the face is highly programmed, selective and specific.
An infant's face is almost round. The length and width of the face are equal and cranium. Face ratio is about 1:8. The face appears to be tucked under the cranial bones at birth, and with growth literally grows out of the cranium. As age advances, the increase in length of face is more than the other dimensions, width and depth, such that in average individuals, the facial height is twice as much as it is in the immediate postnatal period. The remodeling pattern is highly specific. Structures like zygomatic bone, chin, superciliary arches become prominent with age. Apposition resorption pattern functions towards attainment of the adult facial forms.
Pattern represents proportionality, not just proportional relationships at a point in time but change in these relationships over time. physical arrangement of the body at one time is the spatially proportioned parts. But there is a higher level pattern, the pattern of growth, which refers to the changes in these spatial proportions over time.
Cephalocaudal growth gradient is an example of change in the body proportions that occurs in normal growth and development. In the third month of intrauterine life, head constitutes 50% of the total body length. The cranium is large, relative to the face, and represents more than half of the total head. Limbs are underdeveloped. At the time of birth, the trunk and the limbs have grown faster than head and face, so that the portion of the head is decreased to 30%. In the adult, there is progressive reduction in relative size of head, which is 12% of the total head body length. Thus is always an increase in the gradient of growth towards the caudal direction right from the intrauterine life. We could also figure out that greater proportion of head which is seen during birth is reduced in the adult. Even in the head and face at the time of birth, there is a larger cranium and a much smaller face. This increased axis of growth in the caudal direction is called a cephalocaudal gradient of growth. Growth patterns. Human body is comprised of 4 major tissues. They are neural, somatic, lymphoid, and genital tissue. Not all the tissue systems of the body grow at the same rate. Growth of the neural tissues is complete by 6 or 7 years of age. General body tissues, including muscle, bone, and viscera, show an S-shaped curve, with a definite slowing down of the rate of growth during childhood and acceleration at puberty. Lymphoid tissues proliferate far beyond the adult amount in late childhood and then undergo involution at the same time when growth of the genital tissues accelerates rapidly. The neural and somatic growth are the most relevant in terms of craniofacial growth. The maxilla and mandible follow a pattern of growth that is intermediate between neural and somatic growth, with the mandible following the somatic growth curve more closely than the maxilla, which has a more neural growth pattern. Now, and before we continue, it is useful to take an idea about the skull bones.
The human skull is made up of 8 cranial bones that surround and protect the brain, and 14 facial bones that form the underlying structure of the face and support for the teeth. With the exception of the mandible, the bones of the skull articulate with each other through joints known as sutures. Throughout the skull, holes known as foramina serve as passageways for blood vessels and nerves. Bones on the surface of the skull encase the brain, protect sensory organs, and serve as attachment sites for the muscles of the head and neck. These bones include the occipital bone, parietal bones, temporal bones, and the frontal bone, as well as the nasal bones, the zygomatic bones, the maxilla, and the mandible. Other bones become more visible only when looking inside the skull. The sphenoid bone makes up the anterior base of the cranium. It is a butterfly-shaped bone with a central body and 2 pair of laterally projecting wings. These wings form portions of the orbit. The body of the sphenoid features a depression known as the sella turcica, which houses the pituitary gland. Located between the orbits, the ethmoid bone makes up a portion of the cranial floor and also the roof of the nasal cavity. An inferior projection, the perpendicular plate of the ethmoid bone, forms part of the nasal septum. The crista galli projects superiorly from the ethmoid bone and serves as the attachment point for the falx cerebri, a dural fold. Extending laterally from the crista galli is the cribriform plate, a perforated area through which the olfactory nerves pass. The 2 L-shaped palatine bones form the posterior third of the hard palate, part of the nasal cavity, and a portion of the orbit. The small, thin lacrimal bones make up the anterior portion of the medial wall of each orbit. A groove known as the lacrimal groove helps to form the nasolacrimal canal, which contains a duct that allows tears to travel to the nasal cavity. The vomer is an elongated, plow-shaped bone that forms the inferior and posterior part of the nasal septum. The internal and external skull bones articulate precisely, forming an intricate structure perfectly suited to its functions.
Craniofacial skeleton can be divided into cranial and facial skeleton. Cranium can be divided into cranial vault or calvaria, and cranial base, while the facial skeleton can be divided into the nasomaxillary complex and mandible.
The calvarium is that part of the skull which contains the brain. It is the neurocranium. The cranium is made up of a number of flat bones that are formed directly by intramembranous bone formation, without cartilaginous precursors. These bones are the frontal bones, the parietal bones, the occipital bone, the greater wing of the sphenoid bone and the squamous part of the temporal bone. The calvarium has a neural growth pattern. The contact between adjacent skull bones are the cranial sutures. At birth, the flat bones of the skull are widely separated by loose connective tissues. These open spaces are called the fontanelles, and they allow a considerable amount of deformation of the skull at birth. This is important in allowing the relatively large head to pass through the birth canal. 6 fontanelles are present at birth which close by 18 months. After birth, apposition of bone along the edges of the fontanelles eliminates these open spaces quickly, but the bones remain separated by a thin, periosteum line suture for many years, eventually fusing in adult life. Apposition of new bone at the sutures is the major mechanism for growth of the cranial vault. The majority of growth in the calvarium occurs at the sutures. Calvarium growth consists of a combination of displacement due to the expanding brain, osteogenesis at sutural margins, remodeling to increase thickness and change shape. Growth of the calvaria depends on the growth of the brain. It ceases to grow in size by the age of 7 years and all sutures are fused. Cranial base.
The cranial base forms the floor of the cranial cavity and separates the brain from other facial structures. Cranial base is formed by endochondral ossification, and it has a neural and somatic growth patterns. The 5 bones that make up the skull base are ethmoid, sphenoid, occipital, frontal and temporal bones. Now, and before to proceed, it is useful to take an idea about the ossification centers. Ossification center is the site or sites in bones where calcification begins and bone replaces fibrous connective tissue or cartilage. There are 2 types of ossification centers: primary ossification center, secondary ossification center. Primary ossification center. It is the site where bone begins to form in the shaft of a long bone or the body of an irregular bone. Secondary ossification center. It is the site where bone formation continues after beginning in the long shaft or body of the bone, usually in an epiphysis.
Centers of ossification appear early in embryonic life in the chondrocranium, indicating the location of the bones that form that cranial base. As ossification proceeds, bands of cartilage called synchondroses remain between the centers of ossification. A synchondrosis is a cartilaginous immovable type of joint where hyaline cartilage divide and is subsequently converted into bone. In the cranial base, 4 types of synchondroses are seen. They are intersphenoidal, intraethmoidal, sphenoethmoidal and spheno-occipital, or basio-occipital. Histologically, a synchondrosis looks like a 2-sided epiphyseal plate. The synchondrosis has an area of cellular hyperplasia in the center with bands of maturing cartilage cells, extending in both directions, which will eventually be replaced by bone. In this diagram, there is a band of immature proliferating cartilage cells, locating at the center of the synchondrosis, and a band of maturing cartilage cells extends in both directions away from the center, and endochondral ossification occurs at both margins. Growth at the synchondrosis lengthens this area of the cranial base. The skull base can be subdivided into 3 regions: the anterior, middle, and posterior cranial fossae. Anterior cranial fossa. It has a neural growth pattern. It enlarges and increases by remodeling. No farther growth of the anterior cranial fossa between the sella turcica and foramen cecum after the age of 7 years. That is why, after this age, the anterior cranial base is used as a stable reference structure in the lateral skull radiographs. The sella-nasion line is not as accurate, because nasion can change position due to surface deposition and the development of the frontal sinuses. Middle cranial fossa. It has a somatic growth pattern. It enlarges by anteroposterior growth at the spheno-occipital syncondrosis and remodeling. The cranial base is very important in determining the relation between the mandible and maxilla. The growth in length and in shape of the cranial base affects the maxillary-mandibular relationship. Long cranial base or large cranial base angle is associated with a class 2 skeletal pattern, while the short is associated with a class 3 pattern. Maxillary complex. The maxilla is the upper jaw bone, formed from the fusion of two maxillary bones. The two maxillary bones are fused at the intermaxillary suture. The maxilla derives from the first pharyngeal arch and ossifies by intramembranous ossification, beginning in the 6th week, intrauterine life. A primary intramembranous ossification center appears for each maxilla at the termination of the infraorbital nerve just above the canine tooth dental lamina, close to where the infraorbital nerve gives off the anterior superior, alveolar nerve. Ossification proceeds in several directions to produce the various maxillary processes. Postnatal growth of the maxilla follows a growth pattern, which is intermediate between a neural and a somatic growth pattern, but it is more closely neural. The maxilla develops postnatally entirely by intramembranous ossification. Since there is no cartilage replacement, maxillary growth occurs in the following ways: by apposition of bone at the sutures that connect the maxilla to the cranium and cranial base, by surface remodeling, by passive displacement from its articulation with the cranial base. Maxilla grows in a downward and forward direction, and this is accomplished in two ways: by push from behind created by cranial base growth, and by growth at the sutures. Since the maxilla is attached to the anterior end of the cranial base, lengthening of the cranial base pushes it forward. Up until about age 6, displacement from cranial base growth is an important part of the maxilla's forward growth. At about age 7, cranial base growth stops, and then sutural growth is the only mechanism for bringing the maxilla forward. Part of the posterior border of the maxilla is a free surface in the tuberosity region. Bone is added at this surface, creating additional space into which the primary and then the permanent molar teeth successively erupt. In the postnatal growth of the maxilla, bone deposition is seen at the entire inner aspect of the maxillary arch and at the tuberosity. At the anterior concave surface of maxilla, the periosteal concavity from ANS to point A is depository and the periosteal surface, from point A to alveolar margin, is resorptive. The reverse occurs in the endosteal side of cortex, upper half resorptive and lower half depository. The key ridge is an important site of reversal and remodeling. The anterior surface of maxilla till the region of key ridge is resorptive and is concave, facing downwards and growing inferiorly. It is at the region of key ridge, approximately first molar region, that reversal occurs. A lateral surface of maxilla posterior to key ridge and lateral surface of tuberosity are depositary, growing laterally, facing upward. The medial surface of zygomatic arch is resorptive and lateral surface depositary as compensation. Remodeling of the palatal vault. which is also the floor of the nose, moves it in the same direction as it is being translated. The roof of the mouth is carried downward and forward along with the rest of the maxilla, but at the same time, bone is removed on the nasal side and added on the oral side, creating an additional downward and forward movement of the palate. The alveolar margin of maxilla undergoes enormous amount of growth with eruption of teeth. The downward displacement of maxilla and mandible increases the intraocclusal space, enough for the alveolar growth and eruption of teeth. Height is the last dimension to complete growth. Increase in height of alveolar margin accompanies eruption of teeth. Maxillary growth is complete by about 15 years in girls and 17 years in boys. Mandible. Mandible is a unique bone, both by its structure and function. It is a horseshoe-shaped bone with vertical ramus at the end of the horseshoe. It houses the only movable joint of the skull at both its ends. Mandible has a body, 2 ramii, 2 coronoid and 2 condylar processes. It holds the lower set of teeth in its alveolar process. Mandible derives from the first pharyngeal arch. It ossifies intramembranously and it is the second bone to ossify after the clavicle. At the 6th week of intrauterine life, one ossification center arises for each half of the mandible, in the region of the bifurcation of the mental and incisive branches. Then, ossification spreads forward around the incisive nerve to form the incisive canal. Ossification spreads backward around the inferior dental nerve to form the inferior dental canal. The ossification spreads around mental nerve to form the mental foramen. Ossification spreads upward for development of the alveolar process. The bone begins to grow on each side of the tooth, germs become in a groove of bone. The ramus of the mandible develops by a rapid spread of ossification behind and above the mandibular foramen, to form the coronoid process and condylar process. Bone begins to develop lateral to Meckel's cartilage and continues until the posterior aspect is covered with bone. Between 8 and 12 weeks of intrauterine life, mandibular growth accelerate, mandibular length increases. Ossification stops at a point, which later becomes mandibular lingula. The remaining part of Meckel's cartilage continues to form sphenomandibular ligament and spinous of sphenoid. Secondary accessory cartilage appear between 10th and 14th week of intrauterine life to form the head of the condyle, part of coronoid process and mental protuberance. Endochondral bone formation is seen in 3 areas of mandible: the condylar process, the coronoid process, the mental process. The condylar cartilage is replaced by bone, but its upper end persists, acting as growth cartilage and articular cartilage. The coronoid cartilage becomes incorporated into expanding intramembranous bone of ramus and disappear before birth. The mental cartilage ossifies and becomes mental ossicle. These ossicles become incorporated into intramembranous bone when symphyses ossify completely. Postnatal growth of the mandible. At birth, the 2 rami of the mandible are short, condylar development is minimum and there is no articular eminence in glenoid fossa. A thin layer of fibrocartilage and connective tissue exists at the midline of symphyses to separate right and left mandibular bodies. During the first year of life, appositional growth is active at the alveolar border, at distal and superior surfaces of the ramus, at the condyle, along the lower border of mandible and on its lateral surface. After first year of life, these changes occur. Mandible moves and grows downward and forward. Appositional growth occurs on posterior border of the ramus and on the alveolar process. Resorption occurs along the anterior border of ramus, lengthening the alveolar border and maintaining the anteroposterior dimension of ramus. Gonial angle changes after little muscle activity. Transverse dimension is mainly due to growth at the posterior border in an expanding V pattern. The two may also diverge outward from below to above so that additive growth at the coronoid notch, coronoid process and condyle also increases the superior interramus dimension. Alveolar process of mandible grows upward and outward on an expanding arc. This permits dental arc to accommodate the larger permanent teeth. Mandibular growth slows to adult levels about 17 years in girls and 19 years in boys. The term growth rotation was introduced in 1955 by Bjork. He used it to describe a particular phenomenon occurring during the growth of the head. The first implant radiographic study was initiated in the year 1951 by Bjork and comprised of a mixed longitudinal study of about 100 children covering the age period from 4 to 24 years. By means of the implant method, it is possible to locate sites of growth and resorption in the individual jaws and to examine individual variations in direction and intensity. Bjork also analyzed mechanics of changes in intermaxillary relations during growth, and he proved that there is a considerable variation in the development of facial form and intermaxillary relation. Growth rotation of maxilla and mandible occurs during growth, and it has more marked effect on the mandible than on the maxilla, where remodeling disguises its true impact. Bjork gave 7 structural signs to find the direction of mandibular growth. These signs are condylar inclination, mandibular canal inclination, lower border of mandible antegonial notch, symphysis inclination, interincisal inclination, intermolar angle, lower face height. Mandibular growth rotations represent a growth imbalance in anterior and posterior facial heights. The direction and the vertical magnitude of condylar growth and the vertical magnitude of growth at the spheno-occipital synchondrosis influence posterior facial height. Growth of the masticatory and suprahyoid muscles affect the anterior facial height together with the eruption of teeth. A forward rotation, characterized by greater growth in posterior than in anterior facial height, which is more common than a posterior growth rotation. In forward growth rotation, a lower border of the mandible is convex with a reduced mandibular plane angle, and the lower anterior facial height is reduced with a deep overbite. The backward growth rotation, characterized by a concave lower border of the mandible, a pronounced antagonal notch with a high mandibular plane angle, increased lower anterior facial height, and anterior open bite. The pattern of rotation has an impact on treatment. Whereas a forward rotation aids correction of a class 2 skeletal discrepancy, it also tends to increase overbite. And where the rotation is marked, overbite reduction is more difficult. Growth rotations also influence the inclination and anteroposterior position of the lower incisors. A forward growth rotation leads to retroclination of the lower incisors and an increase in lower labial segment crowding. With a posterior mandibular growth rotation, the incisors become upright, shortening the dental arch and producing crowding of the lower incisor area. The growth rotations play an important role in the etiology of certain malocclusions, and must be taken into account in planning of the orthodontic treatment. Growth of the soft tissues. At birth, the orofacial muscles are well developed to allow suckling and breathing, and they soon respond to other functional demands of mastication, speech, facial expression and changes to the swallowing pattern. The light pressures from the lingual and buccolabial muscles affect tooth position, guiding the teeth towards a functional relationship and compensating for any skeletal discrepancy. Where a severe skeletal discrepancy or abnormal soft tissue behavior exists, the dentoalveolar compensatory mechanism will be insufficient. Longitudinally, soft tissue growth can be studied by the following methods. Cephalometrics, facial photographs both frontal and lateral, linear photogrammetric analysis, laser surface scanning. There are two types of soft tissue changes. Soft tissue changes due to growth. Soft tissue changes due to treatment. Facial muscles lengthen with facial growth, which increase the likelihood of lip competence. The timing of the greatest overall change of the soft tissues occurs between 10 and 15 years of age in girls, with a majority of the changes having occurred by the age of 12 years. But in boys the greatest overall change occurs between the ages of 15 and 25 years. In adulthood, soft tissue profile changes take place in both sexes in concert with, but are much larger than, those of the facial skeleton. The nose tends to lengthen and the lips move down relative to the teeth, so, over time, less of the maxillary and more of the mandibular incisors become exposed on smiling. The fullness of the lips also decreases. An increase in chin prominence is common in males, whereas in females, the chin may become more retrusive or show minor change. Control of craniofacial growth. Both genetic and environmental factors impact on the regulation of craniofacial growth, but the exact mechanisms are unclear. In theory, genetic control may be expressed primarily via bone, cartilage or the adjacent soft tissue's functional matrix theory. The current concept is emerging of these second and third theories, bone largely having been discounted. Sutures and periosteal tissues do not determine craniofacial growth primarily, as sutural growth is reactive rather than inherently programmed. The maxillary sutures are not growth centers, but rather growth sites. The synchondroses of the cranial base and the nasal septum probably act as independent growth centers, but the cartilage of the mandibular condyle appears to react to growth. Growth of the cranium and of the orbit in direct response to growth of the brain and of the eyes respectively lend support to the functional matrix theory. Growth of the cranial base, although mainly by endochondral growth coupled with bony replacement at the synchondroses, may be influenced by growth of the brain. Cartilaginous growth of the nasal septum and growth of the surrounding soft tissues probably contributes to moving the maxillary position forward. The soft tissues, including the masticatory muscles, are also contributors to spatial translation of the mandible and to addition of new bone at the condyle. Growth prediction. Growth prediction can be defined as the forecast of growth-related changes with the objective of predicting the direction and amount of the growth of the maxilla and particularly the mandible as well as the timing of the adolescent growth period. Every child extensively differs in the rate, amount and direction of growth and in the expression of the extent of his malocclusion. Patients with class 2 malocclusion, for example, may have only their class 2 molar relation in common, but differ in their parameters of growth, timing of their pubertal growth spurt, the severity of class 2 relation of the jaws and their response to treatment. It is very difficult to predict the response to treatment, especially when the patient is growing. Growth prediction helps in predicting to a certain extent the response to treatment and the growth changes. Growth assessment procedures indicate the growth status of the patient at a particular time and provide an assessment of the percentage of growth left. Methods of prediction: theoretical, regression, experiential. Time series. Growth prediction in orthodontics. Growth prediction is usually not done for all the cases, but only for those cases in which perverted, altered growth pattern is seen. Predicting the altered growth pattern is the most difficult task, because every child has a genetically determined pattern which is acted upon by environmental influences. The advent of cephalometric radiography, among its other frequent utilities, was actually for the study of growth-related changes in the craniofacial complex. Early workers in the field quickly recognized the potential of lateral cephalograms in being used as tools to predict facial growth, especially mandibular growth. It's easier now to classify growth prediction methods into cephalometric methods, non-cephalometric methods. In cephalometric methods, cephalograms form the basis for the prediction that is done in one or the other form of tracing using mesh or grids as reference. This is not to understand that non-cephalometric methods do not use lateral cephalograms, they actually do. But mathematic formulas and allometric equations are used in the forefront to predict the growth. Growth prediction, as applied to orthodontic practice, is mainly the prediction of mandibular growth rather than the growth of the whole face. For example, in skeletal class 2 malocclusion, mandibular growth prediction forms the basis of treatment planning.
Dee-da-da-da-da, 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 dee-da-da-da-da.